Hello, everyone, and welcome to Practical Talks for Family Docs. I'm Janice Harvey, and I'll be your host for today's session, brought to us by RX Files, and it's titled The Art and Science of Medication Optimization for Heart Failure with Reduced Ejection Fraction. Our speakers will review some recent evidence for heart failure therapy and individualizing treatment for your patients. Now, before I introduce our speakers, there are a couple of housekeeping items that I do want to review with you, but I'd like to start, first of all, by reading the Statement of Acknowledgement of Traditional Land. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich and cultural traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you're calling in from as we commit ourselves to gain knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So as with all of our webinars, if you're watching them live, then they are eligible for a certified MainPro Plus credit. And you can claim your credit by just completing a very short survey at the in a link that you'll see in the chat window that'll appear near the end of the session. And that link will be live until end of day Friday. As well, we do welcome questions, so please feel free to put your questions in the chat box, and that's on the right of your viewing screen. If you don't actually see the chat box right now, then you just may need to reduce out of full screen mode. So next slide, it is important that we review our COIs. And so I am a paid employee of the College of Family Physicians in a couple of roles as physician advisor and interim director. I do also receive a salary from McMaster University in my role there, and I receive honorariums for some teaching activities I do with the Ontario College of Family Physicians. So now I'd like to introduce our speakers. So it's Dr. Christine Ryan and Mr. Zack Dumont. So Christine works as a family physician in a variety of settings in rural Saskatchewan. In addition to her evidence-based and trauma-informed care, Christine is very passionate about palliative care. Zack Dumont serves as the Saskatchewan Health Authority's Regina Manager of Clinical Pharmacy Services and is also a clinical pharmacist with the RX Files Academic Detailing Service. Zack's passions include evidence-based medicine, leadership, and information technology. So welcome, Christine and Zack. I'll turn it over to you now, and I will join you later for questions and answers.
Hi, everyone. My name is Christine Ryan, and at this time, I don't have any commercial relationships or interests.
And my name is Zack Dumont. Same goes for me, nothing to disclose. Do just want to share a little bit about the RX Files, as they've contributed a lot of the content to today's presentation. It's a provincial program that receives funding from Saskatchewan Health Authority, or from the Saskatchewan Health, to provide academic detailing for the prescribers of Saskatchewan. The RX Files also receives revenue from sale of printed and digital drug therapy decision resources like our book, our app, and our website. We operate on a not-for-profit, not-for-loss base, and there are just no funding from the pharmaceutical industry to disclose. So as far as mitigating potential bias, not applicable.
So our learning objectives today, we're talking about heart failure with reduced ejection fraction. We want to talk about why it's really important not just to look at the medications people are on, and even if they have heart failure and doing well on those medications and they've seen a cardiologist, why you should actually question the medications they're on and make sure that they're actually on the best evidenced medications for that condition. We'll talk a bit about what those medications are, and then we'll also go through how do you get those patients on those medications. And we'll also do some comparison between the different drug classes and the different agents within those drug classes, and talk about if applicable, when there is a best drug or a better choice within those drug classes. So we've got a poll there. So if you just want to add in your comments or chats, true or false, is heart failure with reduced ejection fraction a palliative condition?
Just put your answers in the chat box. There may or may not be a perfect correct answer, but give it your best go between true and false.
And Zach, I'll just hand it over to you for a minute. I'm going to put my headphones on.
Sure thing. Just still waiting for our first response to come in. We've got lots of people tuned in. That's great. Thank you. Mike Allen and Jeff Sisler tied for getting us kicked off here. Oh, sixth string Brian as well. So we're getting a little bit of true, a little bit of false.
Mm-hmm. Yeah, and I guess a lot of some true, some false. So it's good to actually see a mixed response. And I guess the point of it being, one of the things we wanted to bring up with this poll is a little bit of, so what do we define as palliative? So, I mean, depending on how you define palliative, that'll be a little bit of what you feel that. Generally from a Canadian definition context, a palliative medical condition is a medical condition that is life-limiting or life-threatening that likely cannot be cured. And so heart failure is actually a palliative condition. That being said, though, a lot of people had the points in there. Palliative conditions, just because it's a life-threatening condition that we can't cure, that does not mean that there is not a lot that we can do for those patients. And even though heart failure is, again, in the Canadian context, considered to be a palliative medical condition, palliative care is active care. And we're going to go through all the different things we can actually do to improve patients, not just their quality of life, but as I see Jeff Sisler mentioned there, that, yeah, we can actually improve the quantity of life with heart failure. So if your 70-year-old patient this morning was diagnosed with heart failure, and there's potentially, it's a common condition, so there's potentially someone on this call that did have to have that conversation with a patient this morning, and their ejection fraction is 35%. So they're not too symptomatic. We've got them at a New York Heart Association class 2. What are the chances that this 70-year-old is going to be alive a year from today or 5 years from today? Any thoughts on that? So while we're getting some comments on that. So unfortunately, heart failure is on the rise in Canada. Now, some of that is due to some good reasons, and that's because we're actually seeing people survive. So people are living through their first heart attack. Another, unfortunately, somewhat common contributor to heart failure in Canada is some of the medication. So as a side effect for some of our other disease treatments, unfortunately, including cancer. So some of our chemo drugs do increase your risk of heart failure. We're seeing heart failures on the rise in Canada, and people are also living longer. 600,000 Canadians are living with heart failure. So if you haven't personally been affected by heart failure, someone you know or many people you know have been affected by heart failure. And it's quite an expensive condition. We're spending $2.8 billion on it in Canada a year. So and I don't know if we have anybody. So as people were just thinking about, what if that 70-year-old asked you, what's the life expectancy looking for that? Really at 5 years, we're expecting that once patients have a congestive heart failure diagnosis, 50% of them will not be alive 5 years from now. And that number goes down for the survival rates, goes down if people are having lots of hospitalizations. And additionally, people with, so this is an all-comer number, but people with multiple comorbidities are also going to have a lower survival rate. But it's not all bad. There is actually medications these patients can go on. And so we'll talk about what those medications are in a second here and what the benefits are for them. But unfortunately, what we're seeing and why we're probably still seeing our mortality rates so high in North America and Canada is because when we look at how many of these patients are actually on the medications and being on all the medications that can save the lives, we're not doing that good. So the CHAMP Heart Failure Registry was out of the States and looked at for several years, registered patients with heart failure and looked at which of those patients, or how many of those patients were on different medications. And unfortunately, what we were seeing is not only are not all those patients on the 4 main, plus for some patients, some other medications that'll help them live longer. Not only are many patients not on the medications that they should be on, but we're also not hitting the doses. And another, when I was reading through this study, another really interesting thing I found, and I suspect most of you aren't surprised by this, but there was actually a race difference in the CHAMP-HF study. So in this, again, out of the States, but Hispanic patients were less likely to be on the correct medications and on the correct doses. And so we don't have any, I'm not aware of any Canadian data on that, but I would suspect that there is racial and socioeconomic differences on being on the appropriate medications as well. So just something to be aware of, that we, yes, it is a life-limiting diagnosis and it's not a good prognosis, but there's a lot more we can be doing for these patients. Okay, so we've got patients on some medications and they've been diagnosed with heart failure. And Zach's going to go through why we should actually have them on these different medications and what the benefits of are those.
Thank you. Okay, so it's my opportunity to get a little nerdy here. We're going to go through some of the science behind the different drugs and ultimately what is a combination therapy for the treatment of heart failure with reduced ejection fraction. This screen capture here comes right from our newsletter that we published back in November of 2020. And what this does is attempts to summarize where the hard outcome evidence lies with each of the classes of medications. So as you look down the class of medications on the left-hand side, going through ACEs, ARBs, ARNIs, heart failure beta blockers, mineralocorticoid receptor antagonists like spironolactone, all the way down through digoxin and loop diuretics like furosemide, you can have a look and see, is there any evidence that aligns with mortality reduction or heart failure hospitalization reductions? And we're going to get into a little bit of the nuance behind this table today. And one of the things that occurred during the development of our topic on heart failure back in the fall of 2020 was that this triple therapy, heart failure for reduced ejection fraction triple therapy, it actually started to evolve and change. And there was some new studies published that we're going to have a quick look at, and suggesting that what we typically thought of as triple therapy, being ACE inhibitors, heart failures, beta blockers, and mineralocorticoid receptor antagonists, is maybe a little passé. It's with the old guidelines for sure now, and there's potentially some good reason behind that. Why triple therapy was around for so many years, though, is that when patients were on a combination of medications, that ultimately did improve the likelihood that they were able to avoid bad outcomes. And as you look down the left-hand side of this particular table here, you'll see that the more medications that somebody happened to be on, if they could be on all three of those medications from triple therapy, like an ACE and a beta blocker and a mineralocorticoid receptor antagonist or an ARNI, and we're going to review what all these abbreviations are in a moment here. The more drugs you were on, ultimately, the further you were from this line of no difference, this survival line, meaning that there was benefit with important inpatient outcomes. The fewer medications you were on, so as you go down the list and you get down into single therapy, you can see that the point estimate, the diamond, and the confidence interval starts to gravitate closer and closer to suggest that the life-saving benefit of those medications was diminishing. So the combination of therapy ultimately is panned out and appears to be more beneficial for patients. Now, we were talking about triple therapy. If we were to start talking about quadruple therapy, which may or may not be a coined term just yet, for heart failure with reduced ejection fraction, I'll look to the chat box again for your responses here. What would constitute the fourth drug in that combination, that quadruple therapy combination? So we'll just hang tight here. You can start typing your answer into the box. You can type either the letter or the whole drug name, A, digoxin, B, furosemide, C, an SGLT2 inhibitor like empagliflozin or dapagliflozin, or D, you're just like, there's no such thing as quadruple therapy. Okay, getting some responses come in here. Furosemide, getting some answers for C, the SGLT2s. Okay. All right, so we'll keep we'll keep pouring through here. That really is the answer was ultimately C, if that truly was a coined term, though I don't know if it actually is just yet. The look of core therapy is changing, and no longer is it just ACE beta blocker, ACE or ARB beta blocker, mineralocorticoid receptor antagonist. There may actually be the addition of a couple new medications in here. So an ARNI, okay, we're going to review what that is again, but Entresto or sacubitril valsartan. And on the other end of it, the SGLT2 inhibitor, dapagliflozin, empagliflozin. Okay, so that would maybe potentially make up the fourth drug in what is being coined as quadruple therapy. So let's look at that one first, that class of medications first, the SGLT2 inhibitors and some of the science behind them. And just a little trip down memory lane here. You'll have recall over the last several years, we've seen a number of diabetes studies published with these SGLT2 inhibitors. The Canvas study with canagliflozin, Declare TIMI with dapagliflozin, and EMPA-REG with empagliflozin being the first out of the gate. And what those studies were testing was, do these medications improve outcomes in patients with diabetes? And some of those studies just happened to include patients with heart failure with reduced ejection fraction. And so they started to take another look and look at some secondary endpoints and some exploratory endpoints. And all those studies seem to signal a reduction in heart failure hospitalizations. So they decided to double down on that, and they conducted some heart failure trials. And these are testing SGLT2 inhibitors in patients with heart failure with reduced ejection fraction, independent of whether or not they had diabetes. And we're going to have a look at some of the specifics behind these studies in a moment here. Notably, only dapagliflozin and empagliflozin have been studied so far, and we aren't aware of any studies for heart failure with canagliflozin. A couple notable points here: the DAPA dose was 10 milligrams PO once daily. Same with empagliflozin, 10 milligrams PO once daily. If we look at each of these studies along the left-hand side of this table, there's just some study characteristics there that we're going to dig into. The middle column has the DAPA-HF study, which studied dapagliflozin versus placebo. And the far right-hand column is the EMPEROR-Reduce study, which looked at empagliflozin 10 versus placebo. In each of the study, they had somewhere between 3,500, 4,500 patients. About 2/3 to 3/4 of the patients had class 2 heart failure with reduced ejection fraction. The ejection fraction on average was around 30. Okay, so certainly less than 40, which we typically use to define reduced ejection fraction. The median NT-proBNP, which is a marker of heart failure, was to be elevated in patients. And we also had to look at, or they had to look at the background therapy that patients were on. Were they on a beta blocker? Yes, most were on beta blockers. Most were on ACEs, ARBs, or ARNIs like Entresto. About 2/3 to 3/4 were on something like spironolactone or eplerenone. Diuretics, it was important to look at as well. With DAPA, we know that about 94% of patients, were on diuretics. We don't know about that in the EMPEROR-Reduce study. The primary endpoints that they were looking at in each of these studies was a combination of cardiovascular death plus something else going on with heart failure. And in the DAPA-HF study, it was cardiovascular death or worsening heart failure, which could have been a hospitalization or a visit to an urgent care center requiring IV heart failure therapy, something like an IV Lasix dose. EMPEROR-Reduce, a little bit cleaner, cardiovascular death or heart failure hospitalization. Okay, so that was the plan. That's what they set out to discover. This is what they found. When they looked at the primary endpoint, that composite of cardiovascular death or worsening HF or heart failure hospitalization, what they found is an absolute risk reduction comparing dapagliflozin to placebo of around 5%, 4.9%, and a number needed to treat ultimately of 21. So if we treat 21 patients with dapagliflozin instead of placebo for about a year and a half, we'll see the reduction of that endpoint in one patient. When we look at the empagliflozin study, the EMPA-reduced study, very similar numbers, absolute risk reduction of around 5.3%, number needed to treat of 19. So those are the endpoints as far as the primary, which was the composite of CV death or worsening heart failure. There was the secondary endpoint that they both looked at, which was the all-cause mortality. With dapagliflozin, what you'll actually see is that there was a reduction, a statistically significant reduction of 2.3%, or a number needed to treat of 44. So for every 44 patients we treat with dapagliflozin, adding it on to heart failure therapy, we'll see the reduction of all-cause mortality in one patient. EMPA-reduced did not reach statistical significance. And when we look at these two studies combined into a meta-analysis, what we're seeing on this slide here is the composite looking at first hospitalization for heart failure, cardiovascular death. You can see that in both cases, the two contributing studies are on this side, the side you want to be on as far as reducing the outcome with the line of no difference. And when we pool them together in a meta-analysis, they seem to show a reduction in that particular outcome. If we were to pool the two studies for all-cause mortality, picture is a little bit different. Again, the EMPA-reduced overlaps this line of no difference here. The DAPA study, on the other hand, as we saw a few moments ago with the number needed to treat of 44, was all on this side of the line of no difference. When we pull it all together, it looks like they have a mortality reducing effect. But ultimately, when it came to summarizing this all in our newsletter, we decided on leaning towards the specifics and providing a little more detail rather than just a check mark. You get that dapagliflozin only was the only one that showed a mortality reduction, but both do seem to show a reduction in heart failure hospitalizations. Now, a question that might come up is, what about the doses of the other medications? And one of the reasons that this question might come up is we might start to ask, do we try and get everybody optimized on what was traditionally triple therapy and then add on this medication? Or do we just get everybody on all 4 medications and then start to titrate the other medications? And this particular study from the European Society of Cardiology had a look at that particular question, and they did an analysis of the DAPA-HF study. And I'm going to walk you through a few of the details here. So if we look at the yellow circle here, what that's circling is the triple therapy, the traditional triple therapy of ACE beta blocker and something like spironolactone. And when we look at the outcomes that were associated with whether or not somebody was on less than a target dose, and what they did here was just made it dichotomous. They said if you're on less than 50% of the target dose or 50% or more of a target dose in any of those 3 classes, and we compared the two, does the benefit of dapagliflozin hold up? And as you can see, for sure for ACE inhibitors and beta blockers, and a little bit of uncertainty with the spironolactone class of medications, it looks like the effect of dapagliflozin holds up. Which might indicate that you could go ahead and get this medication started even if a patient wasn't at the target dose or the optimized dose of those other medications. So just to summarize all this stuff on the SGLT2s, as far as safety goes, there were no big surprises. We did see, some of the stuff that had been manifesting in the diabetes trials, the mycologic infections, but they didn't necessarily prove any concerns. Tolerability-wise, we saw that the effect on heart rate was negligible. Blood pressure, really negligible as well. It seems to only drop systolic blood pressure by about 1 millimeter of mercury. We do see a slight worsening of renal function after we initiate these medications. We might see a 15 to 20% reduction in EGFR. We just need to monitor that and make sure that it stabilizes or even comes back in some situations. And we do want to keep an eye out for the hypovolemia that could result from the diuretic effect of these medications, as that could be a risk for hyperkalemia ultimately. As far as efficacy goes, Health Canada has approved the indication for dapagliflozin, and that's based on the reduction in death and hospitalization. Empagliflozin, we do know that there was that reduction in hospitalization, a little bit of uncertainty with respect to mortality reduction. CADTH, or the Common Drug Review, CDR, have recommended to add dapagliflozin to formularies, so we might start to see that added to some of the formularies now. And as far as simplicity goes, the pill burden seems to be relatively low. It's still a consideration, just one pill once a day at 10 milligrams for either medication. And on the titration tapering side of things, this is just a set it and forget it type of medication. Don't have to worry about titration at all. Okay, so that was SGLT2s and the science behind it. We're going to tie all that together at the end with a little bit of the art. Before we get there, I'm going to go through some of the science on the ARNIs. And ARNIs is a relatively a new term, and the only medication in this class right now is Entresto, or sacubitril plus valsartan, and valsartan's a tried, tested, and true ARB medication that's been used for heart failure. The neprilysin component, we're going to have a look at the pathway in a moment here. I'll show you how it works just a little bit different. Of note, we just wanted to mention that all this information is available in our newsletter and our charts, as well as you can find this in any of your trusted drug resources now. Quickly noting that the two components of the medication are usually listed separately. And a practical tip is just to avoid combining the two strengths of the medication. It is best practice to list them out separately. Okay, so now as far as the mechanism of action goes, we aren't showing this pathway to basically just show a pathway and propose benefit. Just wanted to show how these medications work a little bit differently. The valsartan, or the ARB, of course, works on that RAS system. The neprilysin is part of the pathway with BNP, or natriuretic peptide, that gets released with vascular wall stretch, which could be a sign of decompensation in heart failure. So as patients become decompensated and this neprilysin increases, we can block that, and theoretically that's how this is working. But we do want to see, when we've got that theory, we do want to see that there is outcome evidence to back it up. And we do have the Paradigm HF randomized control trial, which was a relatively large randomized control trial. They looked at over 8,000 patients. They had anywhere from class 2 to class 4 heart failure and a reduced ejection fraction. They did have to have an elevated BNP, and that's probably to ensure that neprilysin factor had an opportunity to have an effect. And they should have had hospitalization in the last year. This was another option if they didn't have an elevated BNP, a hospitalization the last year with slight elevations in the BNP. And when we look at the outcomes from this particular study, we could focus perhaps just on this composite endpoint, cardiovascular death or worsening of heart failure. And you can see here again, a number needed to treat of 21, the result of an absolute risk reduction of 4.7%. So number needed to treat of 21 for every 21 patients that we treat for about 2.25 years with Entresto or sacubitril valsartan, we see the reduction in this outcome in one patient. If you want to look, you could see we also have the secondary endpoints, or the components of that composite broken down here. Cardiovascular death, a number needed to treat statistically significant of 31. And so there does appear to be a mortality reduction as well. None of these trials are perfect. We just want to acknowledge that while the Paradigm study has some strengths, and it looked at important clinical endpoints like cardiovascular death and hospitalizations, and they had a quite rigorous protocol, and they were able to follow a lot of patients. Some of the limitations are that the patients were relatively highly selected. They had used a run-in phase, which probably makes sure that patients can tolerate the medication and that they're going to be relatively adherent to the therapy. And also of note, the trial was stopped early for benefit, and there's a few concerns with that, but notably, we don't always get to see the long-term effects of a medication. So where is this ultimately going to fit into therapy? You can see in the top right-hand corner, this is from our newsletter here, still approaching it as an ACE or an ARB or an ARNI now. So it's added into that first quadrant of quadruple therapy. And just to differentiate a little bit where the guidelines are going with this, though, 2017 cardiovascular guidelines, Canadian Cardiovascular Society guidelines, suggested that it be used in place of an ACE or an ARB if you failed ACE or ARB, you remain symptomatic despite good doses of those medications. For the 2021, which were just published, the recommendations changing, and they are now suggesting, based on still on the Paradigm HF trial and the evidence they looked at back in 2017, strong recommendation to continue to use if they remain symptomatic despite being at appropriate doses of those other medications. However, they're also adding on, if you were hospitalized for acute decompensated heart failure, they're making a strong recommendation based on a couple of other studies that have come out, Transition Study, Pioneer HF, that looked at some surrogate outcomes and noticed that we could get better control of something like the BNP or the NT-proBNP and some promising signs with respect to hospitalizations if you started it during that hospitalization. And they're also suggesting that you could use it de novo or as an alternative to ACE or ARB in newly diagnosed heart failure with reduced ejection fraction. Now, that's where the guidelines are going with this. To summarize everything that we just flew through there, we'll come back to that point at the very end of this slide here. With respect to safety, we do want to be cautious with the angioedema. This is not to be used in anybody with a history of angioedema. And quick reminder for anybody who has used this or might be thinking of using this, we really want to make sure that we have that washout period, 36 hours minimum between the ACE inhibitor and the new medication, the sacubitril/valsartan, and that is based on a risk of angioedema. So that washout, really, really important. As far as tolerability goes, like the ACEs and ARBs, no effect on heart rate, negligible. Blood pressure, we do want to be aware of the fact that sometimes these medications can reduce blood pressure. In the Paradigm HF, for example, the Entresto did reduce blood pressure further than enalapril did. Sometimes that's a good thing. Sometimes that can be a little problematic. As far as worsening renal function goes, we don't know a whole heck of a lot about it. We do see those types of reductions with any RAS drug, so there could be a slight decline when initiating the drug. Just of note, the Paradigm HF study did exclude people with more advanced renal dysfunction. Anybody less than 30 mils per minute was excluded, so we don't know about those more advanced cases. We do want to make sure that we're keeping an eye on potassium, just like we did with ACEs and ARBs as well. So as far as efficacy goes, we do know from the Paradigm HF that there would be in somebody who's failed or remains symptomatic on an ACE and ARB reasons to go onto this new medication, this new class of medications. The de novo starts, that maybe a few more questions that we have. Their guidelines are now recommending it, but as far as price and coverage goes, interestingly, this medication's approaching, it's $250, approaching $300 per month for a 30-day supply of the medication. The coverage is still determined provincially. It does appear to be a limited use benefit with the NIHB, so we do see some coverage. Whether we will start to see coverage for these medications being used de novo, that's really where I have a few questions. CADTH CDR has recommended in the past to add this with restrictions really to if you failed traditional therapy. However, they re-reviewed it in the light of the other evidence and the changing guidelines, and just recently yesterday, actually, they came up with another recommendation to suggest that they won't be changing those to include the de novo patients. So do the provincial formularies end up following CADTH and CDR? Not absolutely every single time. We might see some coverage. But we do just want to be aware of the cost. Even if a patient has formulary coverage or it's listed on a formulary and they meet the criteria, sometimes patients still bear the cost of those medications. And if they aren't, then the system is still bearing it too. So there's lots of cost utility benefit analysis to be done here, and we'll see how this all plays out. As far as pill burden goes, it's a medication that's used twice daily, and there is a titration schedule approximately every 3 to 6 weeks, you can increase the dose. And there's some information just to the right of this table here, where you could look and see, depending on if they're on an ACE or an ARB already, you might start at a higher dose if they're already on an established ACE or ARB. If they're on just a lower dose of an ACE or an ARB and you're switching them over to Entresto, you might start at the lowest possible dose and ultimately try and titrate them up to that, what all grand total, this isn't best practice, but what all grand total adds up to 200 milligrams twice daily. Okay, last little bit of science for you before we get to the art on the idea of the combination therapy and the doses, because this is a question that comes up often as we go out visiting our family physicians as academic detailers. With ACEs and ARBs and ARNIs, of note, the science would suggest that the majority of patients enrolled in landmark randomized controlled trials were able to get to the target doses. That's not absolute. There certainly are situations where they couldn't quite get there. So that's where a lot of the evidence lies. When we've done post-hoc analysis or looked at observational data, comparing to lower doses, the higher doses of ACEs, ARBs, and ARNIs do appear to reduce hospitalizations, but maybe not have a difference in mortality. And when we look at the Paradigm HF study in particular, post-hoc analysis of that suggested that when we went to the lower doses, there was an increased risk of cardiovascular death and heart failure hospitalization. So it does appear that should try to get to those medication doses as tolerated, but most people probably can tolerate it. When we look at the beta blockers, the post-hoc analysis would suggest that it might have more to do with the heart rate reduction, and that's what's actually having the impact on clinical outcomes more so than the dose. So you want to keep an eye on that heart rate and push it lower and lower. Probably cap out at the max doses that were used in the studies, and you can find those listed. We'll go over those briefly in a little bit here. But if someone is getting, when I worked in the heart function clinic, we would typically stop if someone's getting close to 50. We would hold the beta blocker there and then see if there's anything else that we could do. With mineralocorticoid receptor antagonists, again, that's spironolactone or eplerenone, and SGLT2s, a little bit more standard doses with each of those classes of medications. The RAIL study, which looked at spironolactone, used 25 milligrams and in some cases titrated up to 50. Eplerenone started at 50 and could reduce to 25 if necessary. But ultimately, a little more standard doses there, and we have. We see those being able to be initiated, occasionally starting maybe at a lower dose, but then titrating up to 25 or 50 milligrams. Okay, Dr. Ryan and I are going to walk you through some of the art here. I'm going to really hand it over to her and get some of her practical pointers.
So we talked about the reasons why we want to have the patients on the quadruple therapy. And so now let's talk about how we get there. And I can see from some of the questions in the chat, there's a lot of understanding that it's maybe not that easy. Next slide. So really, when we're looking at these, just a reminder that the who we're doing this for is for patients with a left ejection fraction of less than 40% who are symptomatic with their heart failure. And we go with the next slide there, Zach. So we want to get these patients on the quadruple therapy. The caveat being that we do understand that there are some patients that have contraindications. So we were already talking about a low ejection fraction, a low kidney function. SGLT2 inhibitors aren't going to be your best friend for that. And we really want to get these patients on those agents at the as close to target as tolerated within 3 to 6 months, which seems like a really long time until you understand that a lot of these medications, as we're titrating them, they're going to require monitoring of blood pressure, of symptoms, and then additionally of renal function as well as potassium. Next slide. Next slide.
Just a quick note from the from this slide here, the guidelines, the 2021 guidelines are now suggesting to strive to initiate the above agents within 3 to 6 months after diagnosis and keep titrating to those maximum tolerated doses. Maximum tolerated doses being very important, as Dr. Ryan just went over there. But this is what the guideline recommendation is, and it's really a fight against that clinical inertia that we might get patients started on these drugs, and then given how challenging it can be to keep titrating them, but we should persevere and look for creative strategies to try and get them to the maximum tolerated doses.
Absolutely. So most of the medications do require that titration. If we're looking at the ACE, the ARBs, and the ARNIs, their dose can be doubled every kind of 1 to 3 weeks for the ACEs and the ARBs, and then the ARNIs every 3 to 6 weeks. And then we're talking about the mineralocorticoid receptor antagonists. We can be going up every 4 to 8 weeks on those patients. And for all these, there's different within those classes, there's different medications, and we'll talk about coming up about which ones you might want to pick as opposed to the other ones. And then just again, that reminder that for the ARNIs, there is those other reasons that there might be some specific patients. So people admitted for severe heart failure or as an alternative for ACEs and ARBs in the newly diagnosed heart failure, not just for people who are still symptomatic on ACEs and ARBs as were the previous guidelines. So how we're going to do this titration is really, really about those patient-specific factors. So we want to, it's kind of that start low, go slow for those really frail patients, but do go. And in regards to how quickly you can go up, really that depends on a lot of stuff with the patient. So the things you want to consider about is their heart rate, their blood pressure, whether their blood pressure is symptomatic or not. So we'll care more about those lows. So some people, these patients will have hypertension, and then we do want to bring it down. We really want to care about their electrolyte levels as well. And specifically what we really are worried about is that elevated potassium. So we don't tend to get as much in trouble with the low sodiums or the kind of lower or lowish potassiums. Our renal function is something to watch, but just be aware not to knee jerk or stop medications just because there's like a 10 or 20% decrease in kidney function. Usually it's more if we're seeing more than the 30%, but it also depends on where those patients are and their volume status. And there's other patient-specific factors that might determine how long it takes you to get these patients on those specific medications. So some of these patients are still working, and so they really can't handle a sudden decrease in their exercise tolerance. So we're going to have to be a lot slower with our beta blocker increases. And as the case for myself, and my patient population, especially with COVID, is getting patients in for repeat labs has become somewhat of a nightmare some days, it seems. And so sometimes you're going to have to wait until you've checked those labs. And if a patient can only get to the place that they can have their labs checked every 2 months, it's going to be a struggle to get some of those medications titrated within 3 to 6 months. And then also there's occasionally some drug interactions we need to be aware of. And also cost can be a bit of a factor, or also trying to get coverage for some of these medications might slow you down a little bit. And that's okay. Just keep working on it. So if you're somebody that really likes having a specific way or a really great start on how to start these medications, the European Society of Cardiology has a paper published that kind of goes through these. So they've separated the medications into different clusters. So they put the diuretics and the SGLT inhibitors together, the ARNIs and the mRNAs together, and the beta blockers and the sinus node inhibitors, and we'll talk about that in a minute, together. And then basically you start, when you're first seeing them in office, you start one from each category. And then when you're following them up, and I like how they have it whenever feasible, as a phone appointment, you can start the other ones, and then they recommend you start titrating them up together. But there's lots of different ways to do this, and it might depend too if the patient in hospital, they live in town, they got other people. My favorite reason for delaying increasing the medications too is bubble packed patients. So sometimes we're working around multiple different factors. But there are, for people, if you like having a recommended way to do stuff, there's an excellent one available for that. So for the ACEs and ARBs, the benefit, when it comes to picking those, the benefit is thought to be a class effect. And RX Files, which is one of my favorite reference books, and it's whether I'm working Emerge, Emerge, clinic, long-term care, or in the hospital, it's one of the reference books that if the internet was out, it's one of the ones I'd want with me. And I use basically on an everyday. They have in their RX files, they only list the medications that have evidence for those doses available. So there's really no major reason to pick one over the other. However, just as a note, RX files also includes cost and whether it's once or twice daily dosing. So for that, ramipril is generally a good option just from the cost perspective, but it is twice a day. And then for if you have to go with an R because a patient develops a cough or for other reasons, candesartan again is cheap and it's once daily, but there might be other reasons to pick the other ones, or you just might be more comfortable with one of the other drugs, and that's okay. For our beta blockers, the effect is not considered to be a class effect. So for heart failure, we only want to be using bisoprolol, carvedilol, or metoprolol. So again, if you've got a favorite one in those, you're probably good to go with it. Sometimes there's patient reasons. So for example, if a patient has really high blood pressure in addition to their heart failure, carvedilol might be a better option for that patient because it's going to lower the blood pressure even more. Conversely, if you have a patient you're struggling with low blood pressures, then carvedilol probably wouldn't be your first choice for that. And then just a reminder, if anyone has any cardiologists in their area that really dislike metoprolol, sometimes the reason for that is because the only available metoprolol in Canada is the metoprolol tartrate, so it's the different salt form. And the evidence is actually with the metoprolol succinate. And so we don't really think that there's a reason that those are different, but technically the metoprolol tartrate that's available hasn't been directly studied in heart failure for these patients. So sometimes if that's enough of a reason for you to pick bisoprolol. And then also just a reminder too with metoprolol that there is the long acting and short acting. So some of them are twice daily, some of them are once daily. And generally we'll start with a twice daily metoprolol. And then switch them over to the long acting because that's preferred. But occasionally there is a reason you want people to have different doses of beta blockers throughout the day. So some people do have reasons that they need to have a higher dose of their beta blocker at night than they do in the daytime. And that's usually due to more AFib or palpitations rather than congestive heart failure reasons. For our mineralocorticoid receptor antagonist, so that's our spironolactone or our eplerenone, again, there's somewhat reasons to pick one over the other. The surprising thing that's kind of a practice changing for me is they are not actually, especially at the lower doses, they are not as much of a blood pressure effect as we once thought they were. They're basically a placebo. And so I think a lot of times these patients didn't get started because, their blood pressure is 105, 110. And really now we're seeing, especially if you've had a patient go to the cardiologists are saying, like, even if that patient's waking up in the morning and their blood pressure is 70/40, as long as they're not symptomatic, they should be taking their MRA. As far as which one, there might be some different patient reasons. The biggest reasons we find is cost. So generally coverage, spironolactone's coverage first. And if the patient develops gynecomastia, which isn't common, but it does happen, then often you can get the eplerenone covered. So as far as other ways we might look at optimizing patient medications, our quadruple therapy, the big thing with those is those are going to save lives. So those are the medications that we want to save lives with. And so all patients should be on those unless there's a contraindication. That doesn't mean though that there aren't other medications we can do. So of note with our congestion, and some patients are really bothered by the extra fluids that they're having on. So that's when our diuretics come in. The one thing just to be careful with that is especially for frailer patients, it does increase the risk of renal dysfunction, of hyperkalemia, and also can be the thing that's limiting us getting those other medications to target. So often that's a piece that as you get their heart pumping better with our ACEs, our beta blockers, our spironolactone, and our SGLT2 inhibitors, get them on those medications at a low dose, back off the Lasix, and then start increasing those other ones. And often you can end up patients that were on, 80, 100 milligrams of Lasix twice a day. They can get down to really low doses of the Lasix or even just PRN as we get those other medications up to target. And then again, we want to get those other medications up to target because they are not saving a life. Not that furosemide isn't giving us some benefit and isn't helpful for the patient. And then just increase the risk of that hyperkalemia. So if you're seeing that might be the one you actually want to decrease, maybe not right away going for the ACE inhibitor. The sinus node inhibitors, so that's the SNIs that were on that European Society Cardiology guideline. So that's ivabradine or digoxin. Those are often used, so digoxin we see used in AFib quite often, so extra benefit there for symptom control. And the ivabradine is often added to patients that at maximal, so when they're at the target dose of their beta blocker and they're still tachycardic, which we know can cause some problems long-term with heart remodeling and stress on the heart. Well, often that's where the ivabradine can be added. And they do, they're not just nothing medications to add, they do actually improve symptoms if you consider how much our patients really do not like hospitalizations. They do help with that. And then we kind of almost want to think about it instead of quadruple therapy. If you have a patient who is New York Heart Association class 3-4 congestive heart failure and is Black race, we actually then almost want to consider it to be like hextuple therapy, because for those patients, hydralazine and nitrate do have an additional benefit for mortality. It's not currently available, and I'm not going to even take a stab at saying it, but you might see in the future that, Zach?
Versigwat.
Oh, so easy. Yeah, and then also I think considering too that for those severe heart failure patients, especially if like their heart failure is bad, or if you've got them on 2 or 3 of their medications and you're not sure and you're really struggling to titrate them up, that's where getting that cardiologist involved can be helpful. And then if you're lucky enough to have those interdisciplinary heart failure clinics or exercise, monitored exercise therapy clinics, definitely those are of benefit for the heart failure patients as well. Yeah. Anything to add? Okay. Anything to add, Zach?
No, nothing to add. I think on this next slide here, we've just summarized that the evidence where it lies with each of these medication classes, and that really ultimately with not as much mortality reduction. Pardon me. We still want to try and favor those other medications, and as you were mentioning on the last slide, if sometimes these medications get in the way of that quadruple therapy, and we have to look at optimizing those first. All right. So I'll take an attempt to summarize here, but I invite you, Dr. Ryan, to come back as well with any concluding points. When we're faced with patients with reduced ejection fraction heart failure, some of the considerations that we think are important for them, and that's a bit of an assumption, but assuming most patients are interested in their mortality and giving themselves the best chance at a long life, and one that is of high quality and not spent in the hospital or frequent hospitalizations, we want to consider the drugs, as we've been saying, that seem to show more benefit there. Ultimately, though, this is a combination medication condition. We are likely going to see combinations of medications used in all of these patients. And while we had the tried, tested, a true triple therapy, we now have to start asking questions like, is maybe an SGLT2 an option in this patient? Maybe do we look at switching to an ARNI? And we can think about that as being add-ons or switches, either in people who are already optimized or those de novo cases, and some different considerations there. We want to remember that formulary coverage is very important consideration. There's costs with each of these medications, and usually a rule of thumb is the newer the medication, the more costly it is, and sometimes the formularies aren't quite covering it. Even if they do cover it, there's someone is bearing the cost. It could be the system, taxpayers, and so we want to make sure that cost benefit is there. When it comes to choosing the medications, if you know that there's a class effect like the ACEs and the ARBs, just can go ahead and choose your favorite. We do in our chart list the ACE inhibitors and ARBs that have evidence associated with them. But for the most part, we assume class effect. Go ahead and choose your favorite. When there's no class effect, like a beta blocker, we would want to know what our options are, and the metoprolol, bisoprolol, carvedilol trio are the go-tos there. And then, of course, letting patient factors guide decisions through initiation and titration phases. When I worked in the heart function clinic, which is obviously a more specialized clinic, we would push blood pressures quite low and heart rates quite low. If someone was tolerating it, of course, if they could get by with a systolic blood pressure of 83 or 85, that was okay as long as they weren't falling over. And that's certainly, not something you'd expect to see with hypertension treatment, trying to push blood pressures that low with heart failure. That was often the case. And then just the idea of pushing against that and fighting against that clinical inertia. Don't just stand there, do something. So we want to work against that. And using shared decision-making processes can help patients make informed decisions. And we don't have to make decisions for patients if we can inform them and help them decide, this is how much this medication might cost. This is the potential benefit that you could see from it. These are some of the side effects to be aware of and some of the tolerability issues to be aware of. Do you want to go for it and take it from there? Dr. Ryan, anything to add?
No, and I'm not sure if we have time for questions.
I think we'll have a few minutes just as I'm scrolling through to the question slide. These trial summaries are all posted on rxfiles.ca if you want to have a closer look at some of the science and the evidence that we went through today. Otherwise, thank you very much for participating.
Thank you, Christine, and thank you, Zach. Thank you very much to both of you for that very comprehensive and detailed overview. We do have a couple of questions, and I will ask that, so in terms of monitoring blood work, how soon after starting an SGLT2 would you recommend checking renal function? Because we do expect a transient decline with the treatment onset. And the same, how as far as monitoring with Entresto, what would you recommend as far as checking renal function?
Well, I'll give sort of a more of a monograph type of response. Usually we would suggest making sure that you have a baseline measurement taken, obviously, and that it should be a relatively recently conducted renal panel. Probably to check for that really acute, you can check anywhere from 3 to 7 days just to see if there's a really acute reduction in renal function, and you would theoretically see a spike in serum creatinine in that time. And then probably in about a month, you'd want to see things either stabilize, and I think that probably goes for either of those medications. Dr. Ryan did a slightly different perspective on it.
No, I would agree with that.
Okay.
Again, with the understanding that with COVID and restrictions and patient travel, if it's not exactly 7 days and it's not 4 weeks, it's 6 weeks, it's better to get the patients on the medication.
Okay, that's a very good point. Very practical. All right, we'll do one more question. And this is with respect to heart failure patients who have stage 4 chronic renal disease. And would they also not be candidates for SGLT2s?
Oh, good question. Again, I can provide some of the science there. Both the Emperor-reduced and the DAPA-HF studies included patients with more significant renal dysfunction than we've seen in the previous diabetes studies, where they were usually capping those or excluding patients below 60, and the monographs were even capping at 45 or 60, depending on the jurisdiction. The studies both included people as low as 30 mils per minute eGFR, and I think even in the Emperor reduced 50% or 48% of the patients had a renal function less than 60 mils per minute. So we're sort of between that 30 and 60 zone. Not quite the more advanced chronic renal dysfunction that you're talking about probably, and so would suggest avoiding it in those patients.
Christine, anything to add? Okay. All right. Well, I'd like to thank both Christine and Zach again. And if Zach, you go to the next slide, just to remind everyone, we have our next session coming up on June 8th. And the webinar is called At a Loss for Weight Loss, Scaling Down to the Evidence for Primary Care. And that will be brought to you by our own peer team. Then we're going to take a break for the summer, and we'll be back in the fall. We hope that you'll join us for our last webinar. And don't forget, as you saw in the intro video, check us out on CFPC Learn. There's a vast array of great resources for family docs, podcasts, webinars that are there that are certified. And speaking of that, don't forget to complete your survey before end of day Friday to get your Main Plus credit for this webinar. Thank you all for watching. Thank you all for everything you do every day, and stay safe.